Now over to Sanjana. Sanjana is our member. Sanjana by profession is dietitian, certified diabetes educator, and now currently attached with Medulla Cancer Cure Center as a consultant dietitian. Over to Sanjana.
Thank you, Indrajita. Well, without much delay, I shall take this to the main point of attraction for today. That is a second session of our very popular A to Z series. First time we got a huge response from this series, so we thought of bringing another session of A to Z series. So, taking no more time, I would like to introduce our first speaker for today's session, Dr. Bodhan Dashmunshi, sir, MD Medicine. He is the Assistant Professor of AIMS, Deoghar, and life member as well as a member of Research Subcommittee of DAY. Welcome you, sir. Welcome on behalf of DAY. I have already muted all the participants and made you the co-host. So you can now share your screen, sir.
Good evening,
Over
everyone.
to you.
I'll start sharing my screen. It's visible. Is it visible?
Yes, sir. Just make slideshow. Just make it
Yeah.
slideshow.
Is it visible right now?
Yeah.
Okay. Good evening, everyone. So I start off with A of A to Z of diabetes. The beginning. Can you see the scene out here? The scene from the famous movie Sholay. If you just judge this scene, then you might think the movie is a romantic movie. But it is essential not to judge by only one scene, but to go through the entire movie, the entire visual representation, the entire story, and then judge. So, if we see the entire movie, it turns out to be an action adventure movie. Carrying this concept forward about holistic visual representation, we come to the topic for the day, which is ambulatory glucose profile, or AGP in short. I'll be talking under these following headings: history, evolution, and need for AGP, definition, indications, device, types, time and range, components of AGP information, and clinical example. How did the story start for ambulatory glucose profile? The first paper was in 1987 by Roger S. Maze, where he did SMBG, or self-monitoring of blood glucose, the finger prick method, which we usually advise to our patients, the 5 or the 6 or 7 readings or the 3 readings. And with that data collected over several days, he formed, or his team formed, a 14-day visual record in a graphical manner. This was the first instance of the concept of ambulatory glucose profile. Gradually, over the 2000s and later in the 2000 and 2010 onwards, this concept gained more ground. We know about SMBG, or self-monitoring of blood glucose, continuous glucose monitoring systems. One is a snapshot, another is a continuous profile. When we talk about glucose monitoring and glucose control, we talk about the destination, that is HbA1c. But is it enough? The destination alone is often not enough. As you can see in this picture, or in this cartoon, there are two HbA1cs mentioned. The one on the left-hand panel, where the cursor is, has a smooth ride, while the other one, just like a journey from Kolkata to Durgapur. However, the other one on the right-hand side has the same HbA1c. However, it has an uneven ride, the journey from Shiliguri to Sikkim, the roads, if you think of. So it's not alone the destination which is important, but also the journey. And because of this, the concept of glycemic variability, or fluctuations which happen in blood sugar, came into existence and came into focus. Why again? Because these have been associated, or the fluctuations which happen have been associated with generation of oxygen-free radicals and endothelial dysfunction, which can lead to complications, especially the microvascular complications of diabetes. While measuring glucose or while having a good glycemic control, there was talk of the glycemic triad, which consisted of the fasting plasma glucose, the postprandial plasma glucose, and the HbA1c. But was it enough? No. That's why the concept of glycemic pentad, where the focus on the quality of life of the patient, as also the journey in achieving the quality, that is the glycemic variability with the glucose parameters being maintained, gained importance. So the concept has shifted not only from the triad to the pentad, but also considering all the parameters for a holistic glycemic control, considering the individual as a whole and not just parts. Let's look at this page. This shows the self-monitoring of blood glucose, that is the finger prick method, which is commonly advised to the patients who are often on insulin or who have an irregular blood control or an irregular regimens. If you can see that these are snapshots or pictures or recordings taken of the blood glucose at a particular point of time. However, these do not provide all the information. This graph again is obtained from the continuous glucose monitoring system. Here, there are lots of skewed graphs, which you can see. It looks like someone has scribbled. And that too is often confusing and not informative for taking appropriate clinical decisions either by the patient or the person who is being given the diabetes care or the caregivers, that is the doctors, educators, and other members of the team. Therefore, the concept of having a holistic guide, a visual representation, which is easy for both these groups to take decisions, came into existence. And therefore, we'll talk about the flash glucose monitoring system with which the ambulatory glucose profile is done in greater details. If glucose, or with this device, the glucose levels which are monitored every 15 minutes continuously for over 14 days, and gradually this information, if you can see, there are many graphs out here, but this graph has been simplified. This looks much better. This looks much clearer. Well, this can, the above one can often be confusing. If this 14-day data is composed into a data that resembles a 24-hour data but gives holistic information, that is what the ambulatory glucose profile shows. It's a visual snapshot of the glycemic data and its descriptive parameters. Why is it important? It's important to know about certain features which we are all concerned during treatment: the rise and the fall, the variation which happens. So, in achieving stability without variability, an easy method which gives a visual representation, which helps to summarize the data of glucose control, and which helps the person undergoing treatment and the healthcare to take clinical decisions easily, that resulted in AGP. There are various types of AGP which has been shown in literature. The several companies ones, the Abbott, Dexcom, and Eversense. Now, why this requirement of this visual representation came? Because there was need for tight or appropriate glucose control in certain groups, like those who are pregnant, those before conception, or if infections are not getting controlled. And the worrisome factor in treatment of diabetes, that is, those with high risk of hyperglycemia, like the elderly, or those who have a very fluctuating manner of glucose control, those with refractory diabetes. Also, when we are not sure about the reports and the symptoms, the individual reports don't go together. So discordant profile between the symptoms of the reports, these lead to use of continuous glucose monitoring system and the representation of its data with the help of AGP. Now, this is the example of the Freestyle Labor Pro system, which is used for AGP monitoring. It consists of an applicator, the sensor, and the reader. How to use it is the key to understanding and applying this instrument. Let's see the video. So you can see the sensor being applied with the help of the applicator, and this is the reader. Okay, so the sensor and the reader. The sensor which senses with the help of a filament, and the reader which helps to take that information. It is placed at the back of the arm usually, so it can often be kept under the clothes, not visualized by any, not a social stigma. It is hardly painful, so it's almost painless. And it doesn't need a lot of calibration. What we are seeing here is an intermittently scanned CGMS, that is, to know the information, the sensor has to have a recorder also. So that's how this device is applied and used. Now, if we come to the advantages of the sensor, important thing to remember is, unlike the SMBG where frequent pricking is required, it is pain-free and repeated finger pricks are not required. Also, it's water resistant. The reader, 8th-hourly, the reader can be used to get the information from the sensor, and this reader can actually be applied to any specialized software in the computer, and the information can be gathered, and this software will convert this information obtained by the sensor into graphs through which action can be taken in management of diabetes. This reader is compact and it can scan through the clothing also. It provides information on the daily patterns of glucose, the glucose pattern insights, and also a daily glucose summary. The sensor has a filament which measures blood glucose from the interstitial fluid. While using the ambulatory glucose profile, there are certain measurements or metrics which become important. The concept of time in range, which has gained predominance since 2017 onwards, is something which has to be known while doing AGP from a CGMS. So let's come to the definition. It is the percentage of the time that a person spends with the blood glucose in a target range. What is the target range? It might vary from person to person, but the standardized ones I'll be coming to. How much? If you can see here, there is a blue dotted line above and below. So this is the range. Anything outside that, up above or below the two dotted lines, is outside the range. Either it can be above or it can be below. So this picture shows the amount of time within the range. The ideal target for treatment is a flat, narrow, and in-range line. If you can see that this graph is within the two dotted lines, the blue dotted lines. The black graph is within the two dotted lines, and it is narrow. It's not spread wide apart. So that is the target. The measurement is done from one midnight to the other midnight. So 12 a.m. to 12 a.m. As I said, the journey is important and not only the destination. So in achieving glucose control with a target HbA1c, it's important that the time in range is also within the accepted norms. Why? Because diabetes complications, especially the microvascular complications, have been known to occur with decreased time within the range. That is, so we come to the targets. What are your targets when we are talking about time in range? If we are talking about persons with diabetes type 1 and type 2, 70% of the time it should be within the target of 70 to 180. Less than 70, it should be less than 4%, and above 180, we should try to minimize. The targets become slightly different for gestational diabetes, where 85% of the glucose should be within the range, and in patients with frail diabetes, that is elderly people who might not have uh, a long lifespan, who might have complications, so there the requirement within the expected time or within the expected glucose control, that is 70 to 180, might be much lesser, but the higher values and the lesser values should be avoided. So also in pregnant with type 1, where 70% time in range is the expected target. Once we know this, once we know the target, once we know what we want to achieve, let's see the graph in reality. There are three components of the graph. The first one, this is the most important graph. You can see the x-axis and the y-axis, the glucose on the y-axis and the time on the x-axis. Now you can see a dark blue line. Can you see which is being shown as the median? So this is the average glucose control over the 14-day period. If glucose is measured by this instrument every 15 minutes for a period of 14 days, and at least 70% of this data is captured, recorded properly, so this graph, if generated, shows that the average or the median is this blue dotted line. Now you can see a darker blue part which is shown here amongst the green with the green arrows. Can you see? The 25th, the lower one is the 25th and the upper one is the 75th percentile. That is, above and below this dark blue line, there are 50% of the values which come. So with regular meals, regular medications, and regular timings, majority of the values will be within this range. Beyond this dark blue portion, there is also a grayish portion. So these are the aberrants which happen. This should be remembered. These represent the deciles, or the 10th and the 9th decile. Above or within, from this above 98% to this 10%, majority of the glucose values lie. Anything outside are the outliers. So we need to see whether the values are coming within this target or not. Once we know this, once we have an idea about this, we also can see the other data which is given by the machine. Over here, you can see that the glucose statistics and the targets are given. The date on which it was measured, the percentage of time CGM is active. Ideally, it should be 70% for a 14-day record and 100% for a 10-day record. And the targets. 70 to 80 is the target, which should be above 70%, that is almost about 17 hours a day. Below 70 is less than 4%, which is about 1 hour per day. Below 54, which comes in the hypoglycemia level 2, that is about 1%, that is 14 minutes or 15 minutes roughly. And above 200, which should be less than 5%. The average glucose is the glucose value, average value over the 14 days, which is given. And if this graph is maintained during the monitoring period, then the expected or the estimated HbA1c which can be obtained is given by this glucose management indicator, which is 7.6. We have also talked about variability or fluctuations. Ideally, it should be less than 36%, which has been obtained from various data. This time in range, which we showed earlier, should be within this green zone. As we know the traffic light system, green is go, red and yellow are not the ones which are preferred. So the above ones and the below ones in red and the above ones in yellow and orange are not the targets which should be obtained. It should be the green which we should go for. And last but not the least, this ambulatory glucose profile also gives information about the daily glucose values. This gray zone is actually the target for a day. The above yellow ones are those which are going above the target or 180, and the red ones are the areas or the times of the day when it is coming below the target. Now, when you're assessing a 14-day pattern, the fluctuation may not be same on every day. If you see this graph, you will see that on 7th and 8th, this Friday and Thursday, and also on this Saturday, the levels going up in the yellow range are more, while it is less in the other, while on a Tuesday, it was more within the target. So this is how the glucose summary can be made and shown in the graphical representation. Time within target, within the gray zone, above and below the red zone. So in a nutshell, if you have to compare the SMBG, CGMS and the information which is represented from CGMS in the AGP format or the ambulatory glucose profile, we should know that the AGP is easy to interpret. It is not dependent on the operator and requires minimal motivation. If you just, in this COVID era, if you just stick it, finger pricks are not required, and skills required are also minimal. So let's come to the example. This is the graph of a patient who has been managed by team Day very recently. This was the graph. If you can see, this 80 to 140 is the set target glucose, and most of the lines and most of the graph is above the target. You can see high values, average blood glucose being 332 to 415, and the daily blood glucose going way above, all in the yellow zone, nothing in the gray zone. Intervention was done in the form of diet, insulin dose changes, also activity changes, and an improvement was obtained. So the former record can be compared to the present record, and then an improvement can be assessed through it. This is the improvement which has been brought. So with this graph, one can make changes to the diet, lifestyle, drug regimens, the medications, especially insulin. Also the time a person gets up, goes to sleep, the time a person is anxious. All these factors can be countered in, and changes can be made to the treatment in the best way for the patient. So in a nutshell, this ambulatory glucose profile empowers the patients and the caregivers, and time in range is the metric which is helpful in achieving this target of reducing glycemic variability, achieving glucose targets, and achieving the quality of life, and also reducing complications. Thank you. If you have any questions, you can kindly ask.
Thank you, sir. Thank you for such an insightful presentation, filled with, enriched with lots of information. We can take some questions, right, sir? Anyone have any question for sir?
Yes.
Yeah, please.
Mm,
Hello.
yeah.
Yeah, please. Go ahead. Hello. You can also write in the chat box if you have
Can you
any.
hear me?
Yeah, we can hear you. You can also write in the chat box if you have any difficulties in sound problem or anything like that. You can write your question directly in the chat box, or you
So
can address.
this was my question.
Can you just repeat the question once?
Hello.
Yeah, just repeat the question for once. I guess there is some connectivity issue.
Sanjana asks all to write the question in chat box.
Yeah, I have already asked Indrajita to write the question in the chat box.
So
If time is
now,
a limitation, we can go forward to the next talk and then
yeah,
take questions at the end together.
Yeah, yeah.
Okay.
we can get to the next topic.
Okay,
Thank
okay.
you. Thank you, everyone.
Okay. Without much delay, moving towards the next session, I would like to introduce our second speaker, Dr. Rakesh Kumar Sir, Assistant Professor of IQ City Medical College and Hospital. He is the Assistant Secretary and Joint Convener of Research Subcommittee of DAY. I welcome you, sir, on behalf of DAY. You can just share your screen, sir.
Okay, thank you, Sanjana, for such a
Yeah,
nice
well,
introduction. And just allow me to share my screen.
yeah. Just allow me.
Have you allowed it? It has been disabled from your side.
Is it now okay, sir? Just say.
Yes, yes, yes.
Thank you.
So my screen is visible now.
Yes, sir, your screen is visible.
Okay. So first of all, many thanks to the Bodhain for such a simple, elaborate talk on such a difficult topic, especially the elaboration of time in range, time above range, and time below range, because these are new concepts and very difficult to understand for people who are not having medical backgrounds. So, so it was a really very simple and good talk. Congratulations, Bodhan. You are back with a bang after such a long time. So, my today's topic is basal and bolus insulin. And before I go directly into the topic, let me start with some introduction of what is insulin. Insulin is a potent anabolic hormone, we all know that, and its absence induces a profound catabolic state that affects fat, carbohydrate, and protein stores. In simple words, I can say if you don't have insulin in your body, you are fasting despite having lots of meal. This is the case in type 1 diabetes mellitus and in some form of type 2 diabetes mellitus. Absolute insulin deficiency, such as that characterized by type 1, will result in death if left untreated. Over the years, most of the type 2 diabetes mellitus will eventually need insulin, because we all know that by the time we make a diagnosis of type 2 diabetes mellitus, we have already 50% less beta cell functioning, and we lose at least 4 to 6% beta cell function every year. So in the due course of time, and due to increased lifespan of the individual because of the improved health infrastructure, more people with type 2 diabetes mellitus will definitely need insulin in the future. Insulin was first discovered in 1921. The Canadian scientist Frederick G. Banting, Charles H. Best, J.J.R. MacLeod, and James B. Collip discovered this wonder molecule. They extracted insulin from the islets of animal pancreas. It was first obtained in a crystalline form in 1926, and the chemical structure was fully worked out in 1956 by Sanger. Modern genetic engineering technique enables specific amino acid in the molecule to be changed, and the molecule subtly altered to form new preparation with advantageous properties for the people with diabetes. Especially, they change the pH and polarity of original insulin molecule to change the solubility as well as the duration of action of insulin. A number of different insulin preparations and analogs are now available just because of this technique. So, human body contains an organ known as pancreas, which has alpha cell, beta cell, delta cell, and our cells of interest are beta cells and alpha cells. Beta cells secrete insulin and alpha cells secrete glucagon, and both are counter-regulatory to each other. When there is blood sugar in the blood, beta cell gets activated and it secretes insulin. It promotes the peripheral utilization of insulin, glucose, as well as increase the conversion of glucose into glycogen into the liver. When we have low blood sugar level, glucagon secreted from the alpha cell gets into action and promotes the conversion of glycogen to the glucose, so that it's a defense mechanism against the hypoglycemia and fasting. So normal blood glucose regulation we just discussed. Whenever we are having meal, pancreas gets stimulated, and by the stimulation of beta cell, it secretes insulin. In the liver, it acts on the liver to form the glycogen from the glucose. In the cell, it promotes the entry and utilization of glucose. Whenever there is low blood sugar level, pancreas secretes glucagon from the alpha cells, and it acts on the liver to secrete the glucose from the stored glycogen. So this is a simple illustration of the blood glucose regulation inside the body. So, and this is one of the very beautiful graph I would love to explain, and it's very important, especially for my type 1 dear friends, because we can see that we are having a green zone. One is linear, and this is linear, and second one is a peak. So the linear green line represents the basal insulin requirement, means even if we are not eating, our body is secreting some amount of insulin in the body, and which is almost equal to 50% of the total daily requirement of the insulin. So my dear friends, especially those who are type 1 diabetes and type 2 who are on the very heavy dose of insulin, especially where if they're not familiar with the sick day rules, or stop taking insulin, especially during the fasting or sick days, because they feel that they are not taking any meal, so they don't need any insulin. So this is a wrong concept. So even if we are fasting, we need some amount of insulin to maintain the normal anabolic process in the body. So lack of insulin, absolute lack of insulin in body will promote catabolism, diabetic ketoacidosis, and consequent complications. The patient will land in the emergency. And the peak represents the prandial insulin surge, which happens after every meal. The stored insulin in the form of granules gets secreted in the bulk whenever we take meal. So our normal body has two types of insulin secretion. One is the basal insulin secretion, and other is the prandial insulin secretion or bolus insulin secretion in response to a large carbohydrate meal. So having said this, so physiological effect of insulin. Insulin is a protein hormone secreted from the beta cells of the islets of Langerhans in the pancreas, whose primary functions are to enable glucose to be transported across the cell membrane. Insulin acts like a key for the lock. Glucose is lying outside the cell, but it will not enter unless and until insulin enables the cell to receive the glucose inside the cell so that it can be metabolized. Insulin also acts to convert glucose into glycogen for the storage in the liver and muscle, to aid the conversion of excess glucose to the fat, to prevent the breakdown of protein for the energy. And this figure summarizes almost all physiological effect of the insulin. On the left hand side, we can see it stops the glucogenesis, glycogenolysis, lipolysis, ketogenesis, proteolysis. Means in non-medical terms, insulin prevents the breakdown of protein, lipid, glycogen, and prevents the formation of glucose from non-carbohydrate product. Also, it prevents the formation of ketones in the body. On the right hand side, we can see what insulin do. Insulin promotes the glucose uptake in the muscle and adipose tissue. Insulin promotes the glycolysis, glycogen synthesis, protein synthesis and uptake of potassium and phosphate and magnesium in the cell. So types of insulin, we can have human insulin prepared by the recombinant DNA technology, but amino acid sequence same as human insulin. Insulin analogues prepared by recombinant DNA technology, and amino acid sequence change in properties, especially onset and duration of action. Now, there are other types of insulin also, depending on the source, like bovine insulin or porcine insulin. These are no more in use, at least in India. So I will be dealing only with the human and analog insulin. So human insulin may be of following types, maybe short acting, we call it regular or soluble human insulin. We use this insulin as a prandial form. Whenever we take this insulin, it should be taken just 20 to 25 minutes before the meal. We will take the discuss the time, at what time each and every insulin should be taken. One is the intermediate acting insulin, that is isophane or NPH insulin. It acts for around 12 to 18 hours, and if used with caution twice daily, it can act as a basal insulin. And third one is the pre-mixture of short acting, that is regular or rapid acting insulin and intermediate acting insulin, and it can mimic basal bolus regimen if used twice, but less flexible than the original basal bolus regimen. Same as per the human insulin, we have insulin analogues. There are also three types: rapid acting insulin, that is lispro, aspart, glulisine; long acting insulin analog, that is glargine, determin, and degludec. Degludec is the ultra long acting insulin, which can act for up to 36 to 42 hours, and is a flat pharmacokinetics, that is there is no peak. Again, analog insulin can also have a premix formulation in the form of 30-70, 25-75, 50-50. The lesser, that is 30, 25, 50, represents the rapid acting formulation. 30-70 means 30% of the rapid acting insulin and 70% long acting insulin. So this is the graph which shows the insulin duration of action. We can see all the rapid acting insulin starts immediately after taking it and can be inside the body for 2 to 3 hours, while a regular insulin can start working after 15 to 30 minutes of taking it and may remain inside the body for 5 to 8 hours, while intermediate acting insulin may have a peak after 1.5 to 2 hours and can be inside the body for 18 to 20 hours, while the long acting insulin like glargine have a flat profile and can be inside the body for 24 hours. Degludec is not here, almost similar, but more prolonged duration of action for the degludec will be there, that is 36 to 42 hours. And determin, many times determin require twice daily dosing in some cases. And this is the summary of the insulin. Prandial insulin, that is rapid acting insulin analogues, insulin aspart, insulin lispro, insulin glulisine. Time of onset is 10 to 15 minutes. Peak is between 1 to 1.5 hours, and duration is between 3 to 5 hours for all types of rapid acting insulin. For human short acting insulin, the onset of action is within 30 minutes. So these, if you are taking analog insulin as a short acting insulin, it should be taken 10 to 15 minutes before the scheduled meal. Now we have an ultra short acting insulin from the Novo, which can be taken immediately before or immediately after the meal. Inhaled insulin not available in India right now, it's Afroza, may start acting between 10 to 20 minutes of taking it, peak between 2 hours and may remain inside the body for 6 hours. Basal insulin, that is, if human, it is analog intermediate acting insulin. One set of action happens between 1 to 3 hours. Peak is between 5 to 8 hours and can be inside the bodies for up to 18 hours. So remember, dear friends, if anyone is using premix insulin in the form of intermediate acting insulin and regular or short acting insulin, they will have two peaks in a single shot. One early peak for the short acting insulin and one delayed peak for the intermediate acting insulin, which the delayed peak will be anything after the 1.5 to 2.5 hours after taking it. So if a person is taking premix insulin twice daily, So that person must have at least 4 meals to cover those 4 peaks, and those meals must be between 2 to 3 hours apart. So other long-acting insulins are, we discussed it, determined, glargine, and degludec. So this is all from my side. Thank you. It's open for the question.
Thank you, sir. Thank you for such a presentation. Anyone have any question? Feel free to unmute yourself, or you can write it in the chat box. I can't see anyone replying in the chat box with questions.
No problem at all. We can have a next session, and we can
Yeah,
have a question and answer session in the last of the.
yeah, sure, sir. Okay. So moving towards the next session. Now, I would like to introduce the main pillar of day, our president, Dr. Devashish Basu, sir, MD Medicine, attached with Apollo Gleneagles Hospital and eminent diabetologist of Kolkata. We welcome you, sir.
Thank you.
Your voice is not audible, sir.
I have not spoken as yet.
Oh.
I want to start refuting the point that welcome everybody to the second session of the A to Z series. It's a very interesting program that was designed last year, and we believe to cover snippets of what is there in diabetes in a very informal, in a very kind of a colloquial, in a very our own kind of.
Hello.
I guess it's got disconnected.
I think.
Yeah.
Just call him.
Yeah.
Hello.
Yes.
Am I audible?
Audible.
Audible, sir.
Dr. Rakesh, please stop share your screen.
I'm speaking on the phone. The whole life has become everywhere, and I think I'll be able to manage. I don't have a slide there, but the topic is diabetes and COVID. And COVID.
Your voice is cracking. The voice is cracking. The voice is cracking. What happened?
Hello.
Now it's clear. Now it's clear.
So we will just. I will come straight to the topic. It all started with COVID-19. That is in the December of 2019. The first case reported from Wuhan, the Hubei province of China, and all what that was discovered was the coronavirus. It's a large family, which almost causes something like the common cold or flu that we know of. And it is actually the most recently discovered coronavirus among the group. And it is called the SARS, the Severe Acute Respiratory Syndrome Coronavirus 2, which is called SARS-CoV-2. And in fact, who declared as a pandemic. Now, we know that initially, from the reports that were coming in from the Wuhan province, Hubei province from Wuhan, they were talking about the comorbidities. The comorbidities word has never been repeated or used so many times, before the COVID came in. And it was said that people with respiratory disease chronic respiratory disease, people with the cerebrovascular disease or cardiovascular disease, in the spectrum of cardiovascular disease, they all have high propensity of having COVID. And in fact, diabetes was talked about as the 8% chance of having
Shut up,
COVID.
idiot.
Hello. So why does diabetes lead to severe COVID-19?
Shut up, idiot.
আচ্ছা আচ্ছা ঠিক আছে ঠিক আছে ঠিক আছে ঠিক আছে ঠিক আছে ঠিক আছে
Can I speak?
ঠিক আছে ঠিক আছে
Is it audible?
Yes, sir, it's audible. Someone is
Yeah.
just unmuting and yeah. Yes.
Yeah. So the people with diabetes, they naturally have increased risk of infection because of the innate immunity defects. And there is increased risk of severe infection due to obviously the increased cytokines. And we all know that diabetes is an inflammatory disease per se. And the potential mechanism is via the the TLR3, the TLR4. This is a runaway immune mechanism. I'm not going into details of it, but what we have speculated is that overactivation of the TL4 signaling that happens in PWDs contribute to the progression of the disease to become, whether it's a mild COVID can become severe COVID and can cause fatality. So the potential mechanism is that COVID-19 will accentuate also diabetes from the other part. That if you're infected with SARS-CoV, due to the destruction of the pancreatic islets, because there is AC2 receptors which have been identified, mortality has been shown higher with people with hyperglycemia. It was shown that people who are coming in with high fasting blood sugar, people who are coming with more than 8.5 A1C, had more than 4 times higher risk of mortality. In fact, there were papers saying that it was 7 times high in terms of mortality. What we need to know is that people with unstable glycemic control with COVID, people with irregular diet, people with reduced exercise, the GI symptoms, the stress conditions. Per se, COVID is a huge stress condition, and we realized in the last fortnight that it is just wreaking havoc all over the country. And people who are getting glucocorticoids or the MABs for the anti-IL-6 receptor antibodies, these are all having high chance of hyperglycemia. So there is a sharp rise in glucose. There are interruption of non-standard methods that is happening in these kind of cases, because we are not sure about the line of therapy. We are randomly giving ivermectin, we are giving doxycycline, we are giving azithromycin, a host lot of medicines, but we are not sure about which one is particularly specific, whether it's a remdesivir or a favipiravir. We have no clue. Yet we are actually trying to save lives. But in the process, what is happening to everyone is that there is increased fear, there is increased anxiety and tension, which is also picking the glucose level up. And these fluctuations of glucose levels, as Dr. Budhan Banbush was saying, that there's Sanjana.
Yes, sir. Yes.
Can you unmute the other participants, please?
Yes, I have already muted all the participants. They are just unmuting themselves, and I'm trying to unmute him also.
Okay. So so basically we have to all be prepared for the guidance for the people with diabetes, that we need to have the contact information of the healthcare provider at home, who is your last
PPT khol yaar.
So this is Korunirathana. This boy is Korunirathana. Contact information of the healthcare provider. So everyone who has a doctor who is known to have diabetes should obviously have a contact person whose number should be shared with all the householders. And of course, if you're an educator like Sanjana, she should have an account of who are the people that this man should be referred to at the emergency point. People should have adequate stock of medications and supplies, and also the supplies for monitoring blood glucose. There should be enough stock of simple carbohydrates. If your sugar is going down, you should have, the glucose tablets, or you should have honey or, soda to pop to manage the, low blood glucose. And ideally, if you can have ketone strips and you're type 1, with poor control, your ketone strips will be of much help. How do you manage these cases? The anti-diabetic medication has to be, as it was routinely done, but the monitoring has to increase now. You have to frequently check your blood sugar, because perhaps you'll not be able to, whether it's lockdown or no lockdown, you would resist going to, meet your healthcare providers, or you would hate to travel by a, public conveyance. So you will sit back at home and keep checking. And if there's any abnormality, you will immediately report. You should maintain the glycemic control. You should know about the SUG rules. The SIG rules are a must for our educators to promote to all and one in these kind of settings, that you should always keep high 4 liters of water if your kidney function and heart heart function is normal. You should keep monitoring your sugar. If you are on insulin, then you monitor also for ketone bodies. You monitor your temperature, and you'll follow your healthcare team's recommendations. So we have some therapeutic principle of glucose management, that for non-critical patients, insulin is recommended, and the basic dose can refer to the out-of-hospital dose. So insulin treatment, when it is done in the severe COVID infection cases, for non-critical cases, just the ward admission, people just having a basic high-flow oxygen, the same insulin injection can be given. For critical patients, the continuous subcutaneous insulin infusion should be recommended. And if there's existing serious glucose metabolism disorder with like water and electrolyte and acid-based disorders, then IV insulin treatment should be performed in combination with aggressive fluid infusion. So we have now categories of mild, moderate, and severe and critical. So we have guidelines of how to go about. But as a diabetologist, and as in the forum of the A to Z for the diabetes educators, we must keep in mind that type 1 should continue be on its basal and bolus, as Dr. Rakesh had alluded to. And during this time specifically, we should have a very, very tight, stringent control, whether it's with the regular or the analogs. If the patient is on pump, then the basal bolus calculation should be done again and again. The insulin treatment regimen should be set according to the principle of individualization, always tailor-made. And the type 2 diabetes in the mild COVID patients with low moderate glucose increase, non-insulin diabetes drugs can be used. Preferably if we are giving a DPP-4 inhibitor, because we have these DPP-4s as targets for the SARS-CoV entry. If you inhibit them, you also inhibit SARS-CoV. So this is a good mechanism that you can think about. But on the other hand, if your patient is sick and you're giving him a GLP-1 RA, be careful that he's not throwing up, he is not nauseous, he's not vomiting, then he can add to the sick day even further. When the patient is having fever and on glucocorticoids, insulin treatment is the best option, because the PP sugars should be controlled with the prandial insulins. And for critical patients, type 2 diabetes, insulin IV injection is recommended. When almost all the patients now are on glucocorticoids, they are often increase between after lunch and before sleep, that period. So it is important to monitor glucose after lunch and before dinner with and also give the right dose of insulin. So these are the basic things that we should all look for. We should continue having metformin, because that's the holy grail. And there are papers, a number of papers talking about saving lives with metformin. And if the patient is not too sick, or patient is acidotic otherwise, just can safely continue metformin. I would always say that patients with COVID-19 with diabetes are always associated with very critical disease, almost varying to the tune of 30%. So 1/3 of them. Prevalence of non-survivors was also higher in diabetic patients with COVID, and it also varied to also 1/3 of the population. So effectively speaking, what we need to understand now is the glycemic target of these critically ill population. We need to have a threshold of no higher than 180. When you start IV insulin, the glucose level should be maintained between 140 to 180. Lower glucose targets may be appropriate in some selected patients, but targets of less than 110 and more than 180 is just not recommended. So there are a lot of task force, being given shapes. We are understanding that the key points that diabetes is associated with the severity, the prognostic markers are increased, the hospital stay increased. In fact, the mortality is also increased in who are getting COVID-19. Glucose levels should be monitored rigorously and regularly, and dose adjustment of the antidiabetic drugs are necessary. Mind you, it will be safe to avoid SGLT2 inhibitors because of the euglycemic ketoacidosis or the dehydration adding to the sick day problem. But there is this DARE study which showed that DAPA study which showed that even the the interstitial edema etc. Is taken care of. So the results are not yet out that way, but good data are coming in. And what is very important is a patient-tailored therapeutic strategies and a multidisciplinary team approach. Let's say with people like Bodhan, Dashmunshi, Rakesh Kumar, Devashish Basu, Sanjana Sengupta, Indrajit Mojumdar, all the team members should be there. And we need to understand what are the thresholds for hospitalization. We need to understand where to put in oxygen to these patients. We cannot randomly hoard oxygen cylinders at home. We will not indiscriminately, remdesivir and other very serious drugs because of the shortage and of supply and the price of it. But we should judiciously start using all the medications that we have in store. So this is in general what we should do. And I am also a very not strong proponent of vaccination at the moment. But if one who is in all our diabetes subjects and friends should be given a pneumonia and an annual influenza. And I believe as flu is the mother of all these kind of common cold diseases, the auntie of that spectrum called corona masi would also be protected if you are otherwise taken your flu shots regularly. So ladies and gentlemen, friends and our children, people with underlying health conditions like heart disease and diabetes, they're definitely 12 times more likely to die and 6 times more likely to be hospitalized with COVID-19. And according to all the standard kind of paper coming in. But make sure that if your diabetes is well under control and you are keeping a check on the good hygienic methods that are talked about, wearing masks, safe distancing, hand washing, etc. It's not that you would have COVID like like the magazine, the newspapers and the media is saying that every odd man in Calcutta is either now a present COVID or had been a past COVID or definitely will be a future COVID patient. It's not actually so. But if that's also the mechanism of a herd immunity, then why not only if you survive? Thank you. So mind you, diabetes is the dynamite if you get COVID-19. So keep that dynamite diffused and not under very high tension. Thank you.
Thank you, sir. Thank
Thank
you.
Thank you, Dr. Basu, taking this opportunity, Sanjana.
Yes, surely.
In presence of Dr. Devashish Basu, our president, I would like to launch the 2 brochures. And Kalpanadi is also here. Kalpanadi, our joint convener of the capacity building subcommittee. Earlier, we promised that we would launch the brochure for the RCCD and the CCDE, third session of the CCDE. So then I'm just sharing my screen. The refresher course on clinical diet, we published the first poster, and there will be another advanced course of on clinical diet, ACCD, that will be starting from January 22, sorry, January 22. Our third session of CCD, July to December 2021. The course fee will be 5,000, but the early bird enrollment opportunity for the day members at the rate of 3,000. That's the brochure for the art CCD. Course director Kalpana Ray, our joint convener of capacity building subcommittee. There will be 5 national advisors from 5 parts of the India. There will be 5 modules and workshop and exit exam. Always calendar. First class on 13th June, second class 27th June, third class 11th July, fourth class 25th July, fifth module 8th August, workshop and exit exam on 22nd August. 3 months course. Course fee is 2,000 for all and 1,000 rupees for day members. And the next session of the CCD, July to December, we are running our second session now. That will be end on June. So next session from July to December. Enrollment will be starting from next Monday. We will post all the thing in our social media today. I'd like to request Dr. Basu to say something.
Thank you, Indrajit. Obviously, this was when we started in the initial days of day, we had objectives of what we are going to do. So how do we raise awareness about diabetes is basically through teaching, education. And today, with COVID days, we understand that online education is the key. So we will start in this field of diabetes education, looking into different topics, specific information to help all our members, all our friends engage and enhance and augment their existing practice skills. And these are wonderfully crafted. If you have done the CCD course, you will realize that even courses for doctors are not that adequately furnished or well preserved or well reserved with adequate knowledge. But here we want to a storehouse of what you have and replenish and fulfill all your ambitions and goals, so that once you are a member of day, once you have been associated with day, you can go out into the open world and claim that this is the organization which has done you some good. So this is the ultimately the moral objective of day. People like Indrajit, actually the pillars, if you talk about, are people like Indrajit, Rakesh, Bodhan, who have been working with us relentlessly and with that social mission in mind. And I'm sure all the people who are attending and who have done courses with us will not only feel that fellowship, of that camaraderie, of that being there with us, being present in the family, but will one day definitely come out and contribute. So please keep your eyes and ears open whenever you get a chance to get an opportunity of people talking about how to get education, how to rebuild or restructure their lives. We are there for you. You give us suggestions and we'll definitely build something out of it to give you back. Thank you.
Thank you, Dr. Basu. Now we will go to the next session. I am stopping my screen share.
Okay. Now coming to the eighth part of the session, I would like to introduce our last speaker, Senior Dietitian Kalpana Ray ma'am, RD and Executive Member of Joint Convener of Capacity Building of DAY. We welcome you, ma'am, on behalf of DAY. You can share your screen, ma'am. I have made you the co-host.
So I am going to explain about nutrition management with case study. Actually, important points is screen every patient at admission for hyperglycemia with at least 2 capillary blood glucose value, 1 pre-meal and post-meal by a glucometer. After admission of a diabetic patient to the hospital, every patient with diabetes should be started on diabetic diet. Kindly ensure that the patient is strictly adhere to the timing and quantity advised in the diet chart. These are all protocols like screening of hyperglycemia in patient hospitalized with COVID-19, admission and on starting steroids. All newly admitted patients are evaluated for diabetes and hyperglycemia. Then CBG testing, then these are all the step-by-step, all are some protocols. This. Now we are going to share one case study in a hospital with diabetes. 66 years male, date at admission was 24/3/21. Complication was the patient was tested positive for COVID-19 on 25/3/21. The patient has diabetes for last 20 years and currently is on insulin. Biomedical report was that COVID positive and diabetes, fasting blood sugars 115, PPS, HbA1c 7.1%, urea was okay, creatinine okay, sodium little bit low, potassium was okay, CRP was 34. As the patient was admitted in COVID-19 ward of the hospital, following all the necessary protocols, dietitian cannot examine the patient directly, but they were keeping constant liaison with ward sister and communicate with the patient party also. Recall of physical examination was taken from the patient party. Anthropometric parameters are weight 72 kg, height was 170 centimeter, body mass index was 24.9 kg per meter square. These are medication. The patient was on insulin, human mixture, 5 units before breakfast, 7 units at night. Then the others, some some medicines are from for like COVID, like antibiotics, gas, then like paracetamol. These are the things. Actually we are concerned about more about diet. So nutritional requirement was for COVID patient and feed the patient. First thing is feed the patient. The patient is not that serious in this patient and the patient can have food. So in this case or for some tube feeding also, first word is feed the patient. These patients always for COVID patients is, though the patient is like diabetic or thin, but still the patient should get high protein and at least moderate calories energy for fighting with COVID. So the nutritional requirements, energy requirement was 1800 calorie for this patient. Carbohydrate requirement 54% of the total calorie, that is 243 grams. Protein requirement 1 gram per kg body weight plus 23 grams, that is 95 grams. Fat requirement 23% of the total, and fat should be good fat, like protein should be high biological value of protein. As the patient was recovering, a semi-solid diet was given to this patient in the hospital. Diet chart was this type: tea, biscuit, then semolina, then egg arrangement 2, then cucumber, orange, soft rice, dal, mixed vegetable, fish 2 serving, then dahi. Dahi is contained like probiotics. Probiotic also very much important for COVID and COVID patient, for all and especially for COVID with diabetes. Then 2 p.m. Musambi, then tea, biscuit, oat porridge, chana, soft rice, dal, meats, vegetables, chicken, stew, 2 pieces, 80 grams, The patient was non-veg, so it was very much easy for us for manage this patient. So nutrient analysis is this. This is the calculation, the full calculation. It comes total 242.5 gram of carbohydrate, protein 96.77, fat was 45.93, and calorie was 1808. Additional supportive therapy, adequate vitamins and oligo elements integration must be supplemented. Essential and branch chain amino acids should always be considered for rehabilitation patient. Probiotic must be considered, particularly if the patient has an intestinal issues. Sometimes patients have some intestinal issues also. During hospitalization, oral nutritional supplements can given in case of malnourished, or if the patient can't have food by mouth properly, then we should give some nutritional supplement also. 52% program in case of dysphagia, moderate to, and fluid intake should be enough. Fluid intake. Case study 2. Today is my 21st day of COVID myself. This is my case. First symptom on 5/4/2020, headache, sore throat, fever and nausea. I was in the home quarantine and isolation. I'm pre-diabetic and hypertensive. The patient was tested positive for COVID on 11/4/21. Past medical history, pre-diabetic and hypertensive. Anthropometric parameters 157 centimeter, weight 59 kg, BMI 23.98 kg per meter square. So my ideal body mean to say, when we will calculate for energy requirement, we will take 52 kg. Because ideal weight is 57, then minus 5, then that is 52. These are all biomedical report, COVID positive, pre-diabetic, FBS, PBPS, CBG, urea, creatinine was okay, sodium also okay, potassium was okay, CRP was only 15. This is the COVID report. After 2 vaccination, this comes only, the virus load was 32 only. It was mild. These are all report. Hemoglobin, etc. These are all okay. This is C-reactive protein, that is 15. This is CT scan value, it was 6, mild. This is medicines for high BP, all max, or then multivitamin, ivermectin, vitamin C, Calpol SOS, gas pass, dogs, and Montier effects. Nutritional requirement, energy requirement 1700 kilocalorie, carbohydrate requirement 54% of total calorie, that is 229.5 grams. Protein requirement 20% of total calorie, that is 85 grams. Fat requirement 26% of total calorie, that is 49.1 gram. This is the diet chart. Roti, veggies, 1 full egg and 1/2. Apple or guava, and musambi and lemon water in the mid-morning. Then again rice, dal, veggies, fish 2 pieces, then dahi, then dab water 250 ml, tea without sugar, herbal tea. I drink lot of herbal tea also for fluid and all, then dab water, then nimbu pani, biscuit 2 pieces, then in the evening muri chira only, like not much, 15 grams, and nuts, mixed type of nuts 12.5 grams. Then and the dinner again, rice little bit and 1 roti, dal, mixed veggies. This is the calculation. had to bring to our nutritive value book, new nutritive value book. It's come 1730 food kilocalories and 85.8 gram of protein. Our target was 85 grams of protein and 1700 kilocalories. It's okay, I think so. So some important points to remember: give priority to foods with a low glycemic index and low glycemic load, that is vegetables, whole wheat, pasta, noodles, atta, roti, oats. Avoid excessive consumption of fried foods. Limit consumption of foods high in sugar, carbohydrates and fat. Choose lean protein, that is fish, meat, chicken, that is egg, milk. If milk is not tolerable, then a patient can have like as curd. Like me, I drink. I have the milk as curd, not as milk. And lassi or matha may have like milk product. Beans after fully cooked, then chola boiled chana, this thing also, and boiled chana with little bit of salt and cucumber, that is tasty also. Eat green leafy vegetables, eat fruits in 2 or 3 servings, whole fruits, try to have whole fruits if the patient can have. If not, then only we can give juices in case the patient can't have the whole food. But if the patient can have whole food, then whole food is preferable than juices. Regular gargling and steamings are very important for home quarantine patient. They can gargle or steam. Steam is very much important, at least thrice in a day. Some breathing exercise, if possible. Breathing exercise is possible in case of like mild COVID with diabetes or with hypertension. Mild in case of mild, but in moderate to severe case, these are not possible. But some apparatus are also there. They can exercise by those apparatus in the hospital also, using those type of apparatus for breathing. Fluid intake should be enough for proper hydration. Thank you for patient hearing. Any question?
Thank you, ma'am. Anyone have any question? They can unmute themselves or they can write in the chat box.
Ma'am, what should be the protein requirement in post-COVID treatment?
For post-COVID, 1.2 to 1.5 gram per kg ideal body weight. Up to 1 month, up 1 to 1.5 months.
Okay. Thank you, ma'am.
Anyone else? Any question? You can ask questions from the previous sessions also. I guess everyone is a little bit. No one have any question? Interested now?
Angana, then we can end this program.
In the program, right? Okay.
So please give a thanks note from the on behalf of day.
Yeah. Would you like to continue? Yeah, Kalpana Devi. Kalpana Devi, you want to say something? Okay, then we are ending this session. Thank you very much, everyone, for being with us. consider our problem and just participate with us in every moment. We welcome you all. Anyone have any question, they can directly ask to the speakers. We will continue this session.
One question. Hello, this is Mathurima. I am having one question.
Hello, anyone is speaking?
Yes.
Just a
Hello,
bit louder,
this is
you are not
Mathurima.
hearing. I can't hear you properly, just a bit louder.
Hello,
Yeah,
am I audible?
yeah, you can. Speak.
Am I audible, ma'am?
Yes, you are audible.
Yeah. Yes, actually, I wanted to ask one question, ma'am. In the first case study, ma'am has told protein portion. In the protein portion, 23-gram proteins must be added on the first case. So why 23-gram protein is added?
Okay, Kalpanandi, are you there? Kalpanandi?
In the first case, ma'am, first case study, nutritional requirement portion, just revise the slides, then they
Yeah, I
mention
can
the
understand. I can understand.
protein requirement 1 gram per kg body weight plus 23 gram. Why 23 gram is added? I just wanted to know that only.
Yeah, I can understand. Kalpanandi, are you there?
23 grams, like extra 20 gram from 23 grams of protein for that is also like 18 to 20% of the total calories for make it like high protein.
Okay, but in the second case, why not added any extra protein?
Extra protein is added because the second case mine that is mine ideal protein intake normal protein intake was like at least 57 grams of protein, but for in this situation for COVID situation I'm taking like 85 gram of protein.
Okay, you just balancing the
Because
protein.
that is also actually I have shown it in two way, because in two way you can calculate. One way is in the first case, in the two way in the second case, that is 20% of the total calorie, because 20% of the total calorie mean that is high protein. Normal
Okay,
protein
so
because
okay.
our like for the height of 5 feet 2 inches, normal protein intake is 55 to maximum 60 grams of protein, not more than 60 grams of protein.
Okay,
Up to
so in
50,
the
55 normal protein intake, and for COVID that is 85 grams. Here
okay,
also added, like
so in the first case you have added the 54% of carbohydrate and 23% of fat. So that means here 79% with carbohydrate and fat requirement. So rest of the 21% is left for the protein requirement. You adding on that, you 23 grams you must be added with that portion. So total is 95 gram. Am I right, ma'am? In that way you have calculated, right?
actually protein requirements depend upon the
Hello?
ideal body weight also.
Okay, ma'am. Okay, ma'am.
Okay, thank you, ma'am, for addressing the question.
Thank you.
Yeah,
Thank you.
yeah, you're welcome. Anyone have any question left? Or I will end the session. Okay, so for today, I'm ending this session. Thank you all for being with us. Thank you. Bye-bye.
Bye. Bye to all.
Yeah, bye.
Thank you all the faculties. Thank you.
Yeah. Thank you, Dr. Devashish Vasu, Dr. Modhan Dashmunshi sir, Dr. Rakesh sir, and Kalpana ma'am. And thank you, Indrajit, for being always support.
Okay, Sanjana, very good job done. Thank you. Thank you.
Thank you. Thank you. I'm ending the session.